Well, good morning. We are pleased that everyone here is joining us. We want to thank you for being with us while we celebrate and draw attention to the fact that the PBM Act has been included in the appropriations package, and of course President Trump has signed that into law. Now, this is legislation that made it through the Senate last year. I'm the author of the legislation, and we got it through the Senate but didn't get it through the House. So getting it included in the appropriations package is vitally important. Now, the reason it has been so important is we have senior citizens that have repeatedly complained about the high cost of pharmaceuticals. So the PBM Act delinks that rebate and that compensation from the pharmacy benefit manager and the insurance company, and it puts the patient as the priority in this process. It also includes an any willing provider provision, which means any pharmacist is going to be accepted to fulfill those prescriptions. Now, I had a telephone town hall last week, and people were complaining about the high cost of pharmaceuticals. We had someone who owned some rural pharmacies in Tennessee, and they were complaining about the pharmacy benefit managers. As President Trump has rightly said, these are middlemen. They do not add value to the process. What they have done is to narrow the options and increase the cost on our nation's seniors. And to get the PBM Act signed into law helps our seniors like Betty, who was on my town hall last night talking about the high cost of pharmaceuticals, and like Victor, who wanted to know when we were going to conduct oversight of the Part D program. And this will help lower the cost of pharmaceuticals. It will allow more choice and more options for our seniors. Now, we have two pharmacists in the House that have worked diligently on this, and much of the credit for getting this through the House goes to them. Congressman Buddy Carter has worked with me from day one. He participated in writing this legislation, and we have worked on this since I was in the House. This is how long we've tried to deal with this issue. His leadership has been invaluable. And Congresswoman Harshbarger out of Tennessee's 1st District, she is a pharmacist. Her son, State Senator Bobby Harshbarger, is a pharmacist, and Bobby has been working on this at the state level. And Congresswoman Harshbarger's leadership, her explanations of how this affects Tennesseans and the value of passing this has been appreciated. I want to turn it over to Congressman Carter for his remarks.
Thank you, Marsha. Well, let me begin by thanking Senator Blackburn for her work on this most important issue. And this is something, as you know, that I've worked on not only since I've been a member of Congress for the last 12 years, but before then. After all, I practiced pharmacy for 40 years. I was the one who had to go to the counter. I was the one who had to tell the patient how much their medication was. I was the one who watched the senior citizens as they tried to make a decision between buying groceries and buying their medicine. I was the one who watched the mother in tears trying to figure out how she was going to pay for the antibiotic for her child. I set as my goal to do something about that because I knew where the problem was. I knew where the problem was, as Senator Blackburn just said. The PBMs add no value to this system at all. They don't bring any value to health care. What they do is drive up cost and limit choices. And that's something that I set as my goal to address, and we have done that. Yesterday was a historic day. I was fortunate enough and blessed to be in the White House in the Oval Office when the President signed the Consolidated Appropriations Act of 2026 that included the PBM reform that Senator Blackburn alluded to. It was a historic day. It is just the beginning. There's a lot more work to be done. Let's make sure we understand that, and we're going to do a lot more work. As Senator Blackburn alluded to, we do have 2 pharmacists in Congress. Diana Harshbarger now is the youngest pharmacist in Congress. I won't tell you who the oldest one is, but she is the youngest one, and she has been a great ally. She's vice chair of the Health Subcommittee on Energy and Commerce, and in that position, she has the ability to influence a lot of legislation that goes forward, and she's going to be a great help in the future. But again, this is something we got to work on, and something just the beginning of what we're going to be doing. Let's keep in mind, regardless of what party you belong to, whether you're a Republican, a Democrat, or an independent, we all want the same thing when it comes to health care. We want accessible, affordable, quality health care. This addresses all 3 of these things. When you talk about accessibility, pharmacists are the most accessible health care professionals in America. 90% of all Americans live within 5 miles of a pharmacy. As pharmacies close, we impact the accessibility to health care. In the last year alone, over 2,200 pharmacies have closed, almost 6 a day. We have got to address that because that's impacting accessibility to health care. This also addresses affordability because it's going to bring health care prices and drug prices down. And it addresses quality because this will improve quality of health care in our country. As Senator Blackburn alluded to, it does 3 things. First of all, it brings transparency. Transparency is the key. On a semi-annual basis, these PBMs are going to have to report to the plan sponsors and to the employers the discounts that they get. They're going to have to see those, and when the employers and the plan sponsors see these discounts, they're going to demand that they share those discounts, either with the patient or with the employer and the plan sponsors. Not only does it do that, but as Senator Blackburn alluded to, it also delinks the compensation of the drug from a percentage of the drug to just a flat fee. That will bring costs down as well. And perhaps most importantly, what it will do is that it will bring CMS will have the ability in Part D Medicare to review contracts and make sure they're reasonable and relevant so that any willing pharmacy provider will be able to participate, and they won't have to do it by losing money on it. That's very important, and that's what's going to really help a lot as well. I'm really, really happy today. But I want to say again, this is just the beginning. I would be remiss if I did not recognize one person in particular, and that's my legislative director, Jack Ganter, who has worked very, very hard on this, and he's worked diligently over the years. And Jack, we appreciate your help. The pharmacy community appreciates your help. I also want to recognize the pharmacists who have advocated for this. This is what advocacy does. This is the result of advocacy. That's why it's so very important for all groups to advocate. Because we are not doing it for us. We're doing it for the patient. The ones who won yesterday, the patient won. This was a win for the patient. This was a win for all Americans. It was a win for health care. This was big. I want to reiterate again, it's only the beginning. We got a lot more work to do. Diana and Jake Auchinslotz have a great bill, Pharmacists Fight Back. Got a lot of good things in it. We're going to chip away at that until we get all of those achieved. We're going to make sure that these PBMs that the Attorney General of Ohio referred to as gangsters, we're going to make sure that they have their day in court. And we're going to make sure that patients who have been taken advantage of over the years, that they're going to finally see some relief. So again, I want to thank you for being here. And now I want to recognize the youngest pharmacist in Congress, Diana Harshbarger from Tennessee.
Thanks, Buddy. I appreciate that. I won't tell you how old I am, but listen, I don't know how much more I can add to what Representative Carter and Senator Blackburn said, but I've been a pharmacist for 38 years, and I've fought for this. This is why I came to Congress, is to help re-regulate everything up here, because the FDA, the crushing, burdensome regulations that is put upon us. Buddy was a long-term care pharmacist. I have been a retail, worked hospital, compounded, sterile, non-sterile. I've done all that. And when you are regulated to death, and who's going to suffer in the end? And when they can't get their medication, it's that little patient. But if you watch the insurance hearings that we had on the health subcommittee from Energy and Commerce, we had the five big insurance companies in front of our committee, and then they went on to Ways and Means. And you could see that they could not answer the questions that we put before them. And it's all about vertical integration with these companies. When the insurance company owns the physicians, the pharmacy, the specialty pharmacy, the clearinghouse, the PBM, that stifles competition. And that's why, as Buddy said, you've had 2,200 independent retailers close. That is, I don't even have a word for that. We are here to fight for those independent retailers and for pharmacists in general, because the cost of doing business is when their store shuts because they're not reimbursed for the medication. And you can't lose $100 on each prescription and stay in business. So as Buddy said, and as Senator Blackburn said, this is just the beginning. This is a giant win, but it's just the beginning. And what was in that legislation, there's permanent PBM reforms that put patients and community pharmacies first, because we are holding those middlemen accountable. This legislation requires CMS to define and to enforce what reasonable and relevant is. They throw a lot of terms around up here, but they never give you a definition. I'm still trying to figure out must and shall, and dispense versus distribute. That was in DQSA. We still can't get a definition on that. And that was years ago. Medicare D contracts, what they actually mean, so pharmacists can't be bullied or pushed around and have a take it or leave it mentality. What this does, it brings real transparency to a system that's been deliberately opaque. A fee-for-service is how this started out almost 40 years ago, when you slid like a credit card machine that said PCS on it, and you sent it in, and all they got was a fee-for-service. It has transformed into something that is not opaque. We don't know where the rebates go. There's many other things I could say. You're an effective legislator when the lobbyists see you coming down the hall and they turn around and go the other way. And that's called a healthy fear. And that's what we want them to know. We are here to take care of business. But it brings transparency to a system that's been opaque. CMS will now be able to track how pharmacists are paid, how PBMs structure their networks, and which pharmacy seniors truly rely on in their communities. And this matters because these PBMs squeeze out the retail pharmacies, and when that happens, these senior citizens lose access to health care, especially in rural areas like, and Senator Blackburn knows this, I represent a rural area in the 1st District of Tennessee. Just as important, this bill ends the perverse incentive that allows PBMs to profit more when drug list prices are higher. I've always asked, how do they set prices on drugs? And then when you talk to a former employee of a big pharmaceutical company, they're like, it's whatever the market will bear. We need to stabilize things across the board, and that's what President Trump's trying to do with his most favored nations. There is no better time in history to capitalize on this, and as Buddy and I and Senator Blackburn have said, listen, we're going to bring transparency, and we're going to make these people accountable. We're going to try to find out where the rebates are. Buddy didn't mention the FTC report, the third interim report that's coming out before their final report. It's scathing already. So if you haven't looked at that, you might want to look at that. PBM compensation should never be tied to a drug's list price, and that practice is what drives up the cost at the pharmacy and sticks taxpayers with the bill. And when you break that incentive like they did in this bill, we lower out-of-pocket costs for patients, protect community pharmacies, and save taxpayer dollars. Listen, I don't have to say any more. This is a giant step. There's much more to be done. There's a lot of legislation out there. I also am carrying a bill, Patients Before Monopolies, that will absolutely say if you're an insurance company, you won't be able to own a PBM or a pharmacy, and that's huge. So there's a lot more work to be done. I appreciate you being here today, and all I can say is you better watch out because we're not finished yet. Thank you. And I want to recognize Representative McKenzie. He's also a fighter in the arena for pharmacy benefit managers. Against them, not for them.
Well, thank you. I'm Congressman Ryan McKenzie, and it's a pleasure to join all of you today. And it is a great honor to join such fighters in Congress. Buddy Carter leading this charge so valiantly for such a long time, staying with it, even when there were ups and downs in that process. He was in that fight, and we made sure that we got it done as a team. As was stated by Congresswoman Harshbarger, they have, and Senator Blackburn as well, leading over in the Senate, they have been in this fight for a long time to bring about PBM reform. And as a freshman member of Congress, when I joined, I saw that we had addressed this same issue in Pennsylvania. As a member of the state legislature, I was on the front lines of the fight for PBM reform at the state level, and I knew that this was an area where we could address PBM reforms, bring about affordability in prescription drugs, and ultimately bring down the cost of health care for Americans. And so I was eager to join this fight and this team of such esteemed legislators who were working on this for many years when I first came to Congress. And for decades, the American people have watched as the healthcare system has been inundated with middlemen and bureaucracy, helping to make insurance impossibly complicated and increasingly expensive. In the face of those challenges, we need to find common sense solutions to introduce accountability, affordability, and transparency into the system, starting with reforming the practices of pharmacy benefit managers and the middlemen like them in the system. As a result of the appropriations bill, Congress is taking important new steps towards delivering that reform that Americans deserve. By requiring CMS to enforce reasonable, relevant, and transparent contract terms, we can help reintroduce accountability into the equation. By delinking PBM compensation from drug list prices in Medicare plans, we are eliminating those perverse incentives that risk compromising value for consumers. And also by ensuring PBMs provide detailed data spending, we can achieve real transparency. So in all of these ways, this legislation does make huge progress for the consumers and ultimately brings about more affordability in the healthcare space by bringing down drug prices. As was said by all of my colleagues, there is more work to be done. And so I have legislation that would make PBMs a fiduciary. I think that is critically important to make sure that they have the same interests as their customers and ultimately the patients that they serve. And so there is more work to be done in this space. We aren't going to be resting on our laurels, but with the leadership of people like Buddy Carter, Diana Harshbarger, and Senator Blackburn over in the Senate, I'm confident that we're going to get that real change that Americans deserve and bring down the price of prescription drugs. Thank you again, and I'll turn it back to Buddy Carter.
Okay. Thank you. Thank you. Okay, we're going to take some questions. Yes, sir.
Well, you mentioned that there's a lot still to be done, so in that vein, I have sort of two questions.
Sure.
One is in the hearings that you talked about, I guess a week and a half ago now. A lot of your colleagues mentioned GPOs, which I
Yes.
hear a lot of discussion about in Congress until that hearing. I'm wondering, even they're defined in the bill, I think, but do they need more work? That's the first question.
No question about it. Now, let's make sure we understand how this works. And Diana alluded to the vertical integration where the insurance company, and let's keep in mind, 3 companies, 3 PBMs control 80% of the market. That is a monopoly. But the insurance company that owns the pharmacy benefit manager, that owns the group purchasing organization, that owns the pharmacy, that owns the doctor. You know who the largest employer of physicians in America is? United Healthcare. United Healthcare, an insurance company, employs 9% of all physicians in America. There's nothing wrong with working for United Healthcare, but an insurance company employs more physicians than anybody in America? That's a problem. And what happens here, and you heard the words opaque so many times here, that's what happens is that when you have this kind of vertical integration, they just make it so difficult to understand, so opaque, that it's just like squeezing a balloon. When you squeeze it in one area, it comes out in another area. And that's what they're doing with the group purchasing organizations. They are taking them overseas now. We need to address that. This is a big part, and you know what Diana was talking about in her legislation that will prohibit PBMs from owning pharmacies. They did that in Arkansas. That was the first state to do it. That's the way it should be. No PBM should own a pharmacy. They're steering patients to their own pharmacies, and that's causing prices and setting the price.
They set the price.
Mhm.
Yeah.
Go ahead.
I will just say, you know, when you look at the pharmacy benefit managers and look how they were put into the system, what the question to ask is, what is the value that they add? And as we have questioned this, it is they do not add a value for the patient. That is why some of us have had legislation that would completely eliminate the pharmacy benefit manager because it increases the cost and limits the options for the patients. And the vertical integration, the GPOs, some of this activity going out of the country causes the concern of what does that do to the price to the Medicare Part D enrollee? What does that do to seniors? What does that do to families who are looking, people that have chronic conditions that want to stay with a certain medication and it gets changed on them, and then they're having to run the traps again with their pharmacist trying to get advice on how they manage this.
So related to that, and this may be more for Rep. Harshbarger, the America First Policy Institute was, when I was talking to them, they were saying that there needs to be more work done on the pharmacy side between the PBMs and the pharmacies.
Yeah.
Is that what your Pharmacy Fights Back does? What does it do in addition to the PBM transparency and rebate bill?
Well, the bottom line is to make it a level playing field. Right now, as an independent pharmacy owner, if I want to go and get a contract with one of these PBMs, you either take it or leave it. There is no negotiating. You'll have what they call a PSAO that will negotiate that contract for you. If they don't want me to contract it, I mean, I can't. If it's a closed network, I have no ability to ask for that contract. What most favored nations does, it allows me to have a level playing field. In a lot of states, in Tennessee, there's a lot of states that have already passed that, but you know, it's kind of like the Supreme Court. They can bring a ruling down, but they don't have an army to enforce it. Neither do the states. Neither does Congress. We have to have follow-up and accountability. You know, as an example, I had a pharmacist out of New Mexico to email me. He said, Diana, I got an Aetna contract, and I don't mind to tell you it was an Aetna contract. He said, this is my reimbursement if the DIR fees remain in place, and this is my contract price if they go away. How can you legally do that? We don't even, when you're trying to reconcile, you know this, when you go down and what is DIR? It's direct and indirect remuneration fees. What is that? I don't know what that is. It's called a clawback. I know that because you can't even set a budget from month to month in your pharmacy because you don't know how much they're going to take back. Some pharmacies that maybe they're independent and they have 10 or 15 pharmacies, they'll take $2 million a year back from them. So even though at the point of sale you hit that button, you dispense, you know what they're going to reimburse you, that doesn't mean that's what you're getting reimbursed because they come on the back end and take it away again. So how can you legitimately practice? The bottom line is, and I know somewhere, and I'd have to go back, they have been quoted as saying, we're going to put them out of business. Mm-hmm. Look at their mail order. Those contracts say you might be able to get your maintenance meds filled once, maybe twice at your local pharmacy, but we're going to mail that to you.
Yeah.
I'm dealing with something in the Senate right now. It's a Stark law clarification because back after COVID, you have oncology patients who, they can mail their scripts. The these oncologists can mail that patient's oral chemotherapy to their door. Do you know they reneged on that rule? And they said, oh, no, the patient's going to have to come and pick it up. Not the family member, not the caregiver, that patient. Marsha, you know, we have vast rural areas in our state. So does Buddy, so does Ryan. The limiting factor in the outcome of that patient is whether or not they get that medication. You're going to depend on a third party to mail that to you, and we could stand here and tell you all day long how many cases where they didn't mail it. It was 2 weeks late. What happens to that patient when they don't have access to life-saving medication? it'll change their outcome for real, or they may get resistant to that particular chemotherapy. I've got it in the Senate, can't even get it out of the Senate. It's not your fault. I know whose fault it is. I'm not going to say it. But I just need clarification. Remember those words, just and reasonable, must or shall, dispense versus distribute. We can't even get a definition for that in the compounding world, which I am a compounding pharmacist. And I have legislation there, but I'm already getting blowback. And I want to tell you something. You mentioned Bobby down at the state level. He plugged the loopholes, like when
Senator Harshbarger.
Senator Harshbarger.
Yeah.
He has plugged the loopholes in that PBM, the Patients Before Monopoly Bill. And another senator told him, the insurance companies are coming after you, and they're going to spend millions to degrade that bill and to degrade you. This is who we're up against, men and women. We're up against these huge insurance companies that don't want us to survive. So, did that answer your question?
Did you want to say
go
anything?
ahead.
And with that, I mean, you mentioned the law in Arkansas that was passed.
Right.
That would stop PBMs from owning pharmacies. There was huge pushback from some of the largest chain pharmacies in the nation when that bill was passed, and they even threatened to
Right.
decrease some of their.
Want to know why? Some of the largest chain pharmacies? You're talking about CVS? Guess who CVS is? CVS is Caremark. CVS, when you talk about, when you say PBMs, you might as well say insurance companies, because it's the same thing. It is the same thing. Right now, out of the top 16 companies in America in terms of revenue, 3 of them are insurance companies. Number 4 is United. Number 6 is CVS Caremark. Number 16 is Cigna Express Scripts. So you're talking about this vertical integration that we're talking about, and I want to mention just a couple other things. First of all, I want to applaud the president. He's got the right idea here. He has said, stop sending the money to the insurance companies, start sending it to the individuals. That's what we need to be doing. We need to create a competitive marketplace. Let the patients decide where they're going to get their insurance. Don't send it to the insurance companies. That needs to stop immediately, and I applaud him for that. He gets it. He understands what's going on here. You mentioned how big the insurance companies are. United, they got their own bank. They have their own bank, folks. This is how big they are and how egregious it is. One of the first pieces of legislation I passed when I became a member of Congress was to do away with the gag clause, to tell you how egregious these practices of these PBMs was. Whenever you would sign a contract with a PBM, there would be a clause in there that said that if the price of the drug, if you paid cash, was less than the copay, the pharmacist couldn't tell you. If you were the pharmacist and you had signed that contract and you told the patient, hey, if you want to pay for this, it's only $4, whereas your copay is $35, you would get kicked out of the plan. You would get kicked out of that network. We did away with that. President Trump signed it during his first administration. It was doing away with the gag clause. We were gagged as to what we could tell them. That's how powerful these are. That's why we've got to do something about this. And there is, as I said earlier, there's a lot more work to be done here.
Yeah. Someone on the back with a question? No? Okay. All right. Well, thank you all. We appreciate it.
Yeah, thank you.
Thank you so much.
Oh,
It was awesome.
Happy
Awesome.
to do
Great
that.
work. Congrats
Yes,
again.
really.
Well done
What a
over in the
pleasure.
Senate.
Thank
Very
you.
nice to meet you.
Give me
Good
hugs.
work.
I appreciate you mentioning Bobby. Senator Reed tells me that you're going to mention him.
Is that bad? That is so bad. You want your card back? You know what, Diane?